So I'd like to just share with you a brief summary of the presentation that we made about the use of tamoxifen and its effects upon mutant allele burden and disease course in patients with MPN. So this is a study that was done by a large collaborative group based on previous work from Simon Mendes Ferrer, who actually made the presentation at the ASH meeting. So the study is called TAMARIN. You can see the lovely animal logo, and it's a therapy acceleration program trial supported by Blood Cancer UK and run by the CR UK Clinical Trials Unit in Birmingham. So here is the schema for the study on the right-hand side of the slide. You can see that the main aim was to reduce the mutant allele burden at 24 weeks by 50%, and the secondary outcome was to reduce it by between 25 and 49% also at 24 weeks. To be eligible, patients had to be aged over 60 or postmenopausal if they were women. That's based on the side effects of tamoxifen, and they had to have a detectable allele burden, so we deemed that to be more than 20%. We would not include patients who were treated with interferon alpha or other new agents. We started the patients on 20 milligrams of tamoxifen, which is a pretty standard breast cancer type treatment dose, and escalated to 40 at 12 weeks if the allele burden hadn't changed. And on the right, you can see the schema that we were following for the trial. We recruited a range of patients. Mostly they were older, and the majority of them were male. There were a smattering of all of the different disease types in the classical MPNs, and most of them were at least 7 years from diagnosis, some shorter, 0.4 years, and some a long time, up to 22 years. The majority of patients were previously treated or currently treated with hydroxycarbamide, but a range of prior treatments were given. And just to be clear that we were continuing the patient's current treatment, whether that be hydroxycarbamide or just watch and wait, or ruxolitinib, for example, and adding the tamoxifen. So this is a rather complicated slide, but it summarizes beautifully the primary endpoints of the study. So you can see we registered 38 patients, 37 of them started treatment, 35 completed 12 weeks, and 32, so a good number, completed 24 weeks. 31 of those 32 continued on beyond 24 weeks because they felt they were benefiting from the drug. Importantly, related to this side effect profile of tamoxifen, we saw 2 thrombotic events, one after discontinuation, superficial thrombophlebitis, and 1 DVT after 20 weeks of treatment. And if you look at the swimmer plots, obviously each of these represent a patient. You can see that there were actually 3 major responses. One was discarded. There were 4. One was discarded, this one here, because we couldn't validate it. And there were 6 minor responses. Now, that's really interesting in and of itself, that you can give tamoxifen treatment and lower the allele burden in these patients without altering anything else. But the really interesting data from this presentation was the work done in Simon's laboratory and by his team. So here you can see RNA-seq from peripheral blood CD34 cells at baseline, and you can see that this perfectly clusters and differentiates the responders, here shown in green for those meeting primary endpoint, and here shown in amber for those meeting the secondary endpoint, and the non-responders here in red. Important to note that there's some variability, of course, in JAK allele burden, so it was important to look at week 24. So not only can patients respond to tamoxifen with a reduction in allele burden, but you can maybe also predict, actually, and this data looks like you can predict pretty well who is going to respond at baseline and who isn't. What about mechanism of action of tamoxifen? So look at Simon's presentation for a full explanation of this. But basically, we could also segregate responders, here in red, versus non-responders, here in blue, in terms of activation for STAT3, STAT5, and inflammation. And also here you can see responses in terms of starvation, reactive oxygen species, and apoptosis. Looking in more detail, they evaluated the OXPHOS gene signature, and again were able to differentiate responders versus non-responders. But if you look at this image here, you can see that we could also see a difference before and after treatment in responders in terms of the OXPHOS signature. And this was also assessed in cell lines and different up and down regulation of different genes. And you can see a variety of work here, which is explained in more detail in his oral presentation. This was further investigated, thinking about the effects of tamoxifen on mitochondrial complex 1 inhibition, and the way that this can be bypassed by succinate. And here is an image just displaying mitochondrial complex 1. It's part of a complex, excuse the pun, array of different proteins in the mitochondrial membrane. And so what the team were able to do, in brief, was show that the inhibition of that STAT5 activation could be overcome by succinate, demonstrating that it's possible that the effects of tamoxifen were actually mediated by its effect on complex 1 in the mitochondrial membrane. So the conclusion of this study, which is interesting because it introduces a novel treatment and also scientific rationale and a way of predicting those patients who might respond to tamoxifen, is shown on this slide. So basically, we had 3 patients, that's a 12th of the patients, so 8%, achieving a 50% reduction of mutant allele burden within 6 months, which is faster than perhaps you'd expect with interferon. A further 5 patients meeting the secondary endpoint, and that we could identify these based on their transcriptomic analysis at baseline. So the plan is to consider taking this forward, but we have to be very cognizant of tolerability of tamoxifen and its effect on thrombotic risk, as these patients were specifically chosen to have a minimal risk of thrombosis. They were all patients who had well-controlled disease with no prior thrombotic event. So we need to think very carefully about it. And this slide particularly acknowledges the trials teams, the steering committee, the coordinating team in Birmingham, the laboratory of Simon, and the TAP network in the UK. Thanks for the opportunity to share this data with you today. So this data is very interesting because it proves that tamoxifen can indeed reduce the allele burden in these patients. And furthermore, that we can predict those patients that will respond. The challenge is twofold, really. Looking at a side effect profile and deciding which patients might be suitable for a tamoxifen or tamoxifen-like agent, but also in the ongoing quest to really prove the benefit of allele burden reduction in MPN patients, which we first did recently in the context of the MAGIC study, but needs validating. So, as ever, much more work to do, but an interesting new avenue in this disease, which may also explain some of the gender differences we observe in terms of patients' presentation.